Hello. My name is Barbara Cochran. I'm the director of the Deternier Center for Healthy Aging here in the School of Nursing. And today I am representing the Northwest Geriatrics Workforce Enhancement Center, which is putting on this geriatric healthcare lecture series for you. I do want to give a couple of preliminary pointers for those of you, if this is your first lecture in this series. Please check in with your site coordinators so that you will fill out a profile form. We need a profile form once for each series. So once you've filled it out, you don't have to fill it out for any other lecture this winter term, but we do need it once. We use this information to report to our funding agency so that we can continue to offer this lecture series in future years. I also want to mention that if you want continuing education contact hours, your site coordinator has an information sheet that will show you where to log in to get those contact hours. And it's $45 for the entire series, and you can sign up at the end of the series or in the middle of the series or whatever. But that's one of the reasons we also have a sign-up sheet, because we need to back up the attendance for the purposes of contact hours. I'm very, very happy to introduce to you today Dr. May Reed. Dr. Reed is an associate professor in the School of Medicine's Division of Gerontology and Geriatric Medicine. She's also section chief of the Geriatrics at Harborview Medical Center and the medical director of the senior care clinic there. She has a long-standing research interest in evaluating the effects of the extracellular environment on tissue repair and microvasculature and aging. I think it's safe to say you won't be going into that today.
No, not today.
She has projects in the laboratory focused on the regulation of extracellular matrix in aging or injured skin and brain. But today she's going to share with you her expertise on Medicare provisions and promises. And I completely admire that you're taking this on so soon as we head into an administration that may be changing everything.
Well, yes. So I think everyone can hear me. Thank you, Barb. Glad to be back here. I hear an echo, so I want to make sure that everyone can hear me. I am talking directly into the microphone, so I assume that the volume is okay right now. So my purpose today was to talk primarily about all of the additional provisions and promises to patients that have been afforded under the Affordable Care Act. By all accounts, most of these provisions, if not all, are going to stay in place, largely because not only are they good for patients, they're probably going to be good for the Medicare bottom line. So it's very unlikely that any of the provisions I'm going to talk about today that were discovered and facilitated under the Affordable Care Act are going to go away anytime soon. So my objectives today are to describe how preventative care options have evolved under Obamacare or Affordable Care Act, how evaluation of depression and dementia, two key aspects of the geriatric health evaluation, are now changing and continuing to move forward. Define some of the new alphabet soup measures, which include TCM, CCM, ACP, and how those provisions are moving forward and changing quite frequently, but I think much of what you'll hear today is going to just get better as we continue to care for older adults. I do not have any disclosures, and I do want to note I am not going to discuss MACRA, because MACRA is a payment system to pay providers. This is about provisions for our patients. So that is the primary foundation of what we're going to be discussing today. So the first thing that I would like to cover is the whole concept of preventive care under the Affordable Care Act. This is something that many of us struggle with who take care of older patients, and I think the following two scenarios are going to illustrate why. Meet case number one, which is Mrs. G.E. She's 86. She's got treated hypertension, osteoarthritis, and some stress incontinence. She comes in for her 6-month visits and wants all of her health care, preventative care updated. Her BMI is 28, and her labs and physical exam are completely unremarkable. what preventative care would someone like this receive? In contrast, her good friend, Mrs. E.G., is also in her mid-80s, but she's got poorly controlled hypertension. She's got chronic kidney disease stage 4. She's got hyperlipidemia, coronary artery disease, peripheral vascular disease. She's very thin, looks frail, and has stigmata of vascular disease, and her labs are notable for not only her kidney disease, but a significant anemia. And okay, so what kind of preventative care should she receive? 2 women, similar ages, but very different in terms of what you feel would be best for them. So under the Affordable Care Act, there's this concept called Medicare coverage for wellness, and this is something seniors have always wanted. And what it's been in effect, actually now, it'll be 6 years since it started in January of 2011. And many of you are familiar with the wellness provision under the Affordable Care Act, so I'm not going to spend too much time on this. And as you probably know, it started with the concept of a welcome to Medicare if you were someone who's in the first 12 months of your Medicare provision. And basically the concept was to sort of get you enrolled and focus on healthy aging. It was one time, it was free, it's easy to do, no copayment or deductible for that visit. And once you have that visit and sort of have that template in place, you then move on to being told that you're going to get a yearly annual wellness visit, also for free, no copay, no deductible. But those provisions, and we're going to go quickly through some of the checklists of those provisions, really highlight how difficult it can be, though, to focus on a preventative care aspect in many of our complicated older patients. So the first concept was this first annual visit. And without belaboring it too much, it was pretty extensive in many of the things that people who provide care for geriatric patients care about. That includes review of medical history, social history, risk factors for depression, functional abilities, level of safety, not very much in the way of specific physical exam, but parameters of what we think are healthy aging, including BMI, visual acuity, blood pressure, and basically mostly focusing on the things that will keep someone safe. And it also had a provision back when it first started of possibly discussing advanced care planning. And it was reimbursed about $170 to $180 for just the provider fee on that first visit. And the typical visit was very scripted in that you had to have a big checklist in order to make this visit count. So what that meant was you had to come in via medical assistant, you had to have a progress note, you had to have a brief written plan, and a big emphasis on education, counseling, and what are you going to do next based on what you found during that annual wellness visit. Excuse me, I'm going to go back. Sorry about that. So what that meant, though, was that you needed to have a format, a system to make sure that it didn't interfere with the entire clinic workflow in order to get these annual wellness visits done. And so much of that focused on the concept of easy navigation through your electronic medical record. And different systems have had different levels of success in instituting this. Remember that much of it is a checklist format. So if you had the right EMR working for you, not only could your patient check off most of the format before you even come into the room, but your MA, your medical assistant, would be able to complete most of the intake questions before you even came in to do the rest of the visit. So the problem with the annual wellness visit, not only, maybe not so much that initial wellness visit, but the subsequent wellness visit, is that patient expectations very much varied depending on what is the most important thing to them in their own health care. And so what many providers found is that during the annual wellness visits, patients wanted to talk about other things. And those other things included their back pain, their headache, all of the things that bother them that were impacting on their functional status. So there have been quite a few very, very successful groups that have added either a modifier 25 to these annual wellness visits for E&M services that are added on if you have that kind of time, or creating a template so that the patient could come in again at a second visit, which is not always the most feasible things for patients in terms of transportation. So one of the things that more and more groups have been doing is trying to set expectations for these annual wellness visits. including Dear Patient letters, just pointing out that these wellness visits really focus on keeping you healthy and prevention, and that the concept of a physical in these annual wellness visits could be sometimes just a weight check, vision check, a blood pressure check, and really not the type of in-depth physical that some patients thought they were going to receive. They also have to be told that if they do bring in other concerns during these visits, that those are going to have to be either tagged on if the provider has time, or possibly another visit had to be booked for later in that week, or maybe later that month, or maybe in a whole nother month if other things came to rise during these visits. So setting expectations has probably been one of the most difficult aspects of these annual wellness visits, and not only in terms of changing the jargon of what these visits mean, but what to do if something serious is discovered during these checklist type visits that were required to get reimbursed by Medicare for these. So that really has brought to the attention of many geriatricians, well, now that we have all of these provisions for annual wellness visits, how do we decide how much time you're going to spend on prevention relative to actually dealing with the kind of day-to-day problems many of our patients struggle with? And it's really the concept many of you are familiar with who take care of older patients, that it's really got to be about physiology, not chronology, in terms of which patients really should have an entire checklist done and a big focus on preventative care versus those who are actually dealing with so many chronic comorbid issues that their preventative care checklist is really just going to be limited to their immunizations and maybe some home safety checks. And so with that, we had to decide, well, what is in the annual wellness visit that geriatricians should take home from that? And the two things that have really come to play that many people have been very appreciative of has been the focus on screening for depression as well as screening for cognitive impairment. And both of those are really something that in the past had not been templated as something that you would do as part of a yearly visit with an older patient. And with that, if you want to say, well, what exactly does it look like? Well, in practice, and many of you might know this, it was really the question of, do you feel like you are doing well in terms of your health? And then for the depression screen, it was simply asking whether or not you failed on a PHQ-2 type of screening questionnaire. And so what that meant was that for the MAs, there was a lot of emphasis on doing the kind of things that we feel in geriatrics are very important, but that didn't necessarily get reimbursed before the Affordable Care Act had this annual wellness visit format. And in fact, if you look at what the questions were for something like signs of cognitive impairment, it was something just as, does anybody, including yourself or anybody who know you, worry about your cognition or the way you think? And a simple yes to that portion of the annual wellness visit creates a sort of cascade of options in terms of how much you're going to work up the concern that really was never sort of part of our planning or clinic visits in the past. But once you wrap all that up though, and you've got this patient and they've kind of toe the line of what's part of the annual wellness visit, and you've done your screenings, then it's up to the provider though to put together a plan for the year that included not only have I reviewed all the concerns that are in the checklist, but here's what I'm going to do about them. Here's what I'm going to do about basics like immunization, etc. And I have thoroughly discussed this, and I plan to follow up with this patient in such and such a specific time. So although that all seems like a whole lot of checks and marks off and paper, turns out that many practices have in fact figured out how to make this a part of the Medicare patient's care, how to do it effectively, and how to do it in a way that actually does not interfere with workflow and does improve the bottom line. Okay, so that's enough about the annual wellness visit. But within that, I do want to spend a little bit more time about the depression issue and how the annual wellness visit and many other provisions of the Affordable Care Act have really allowed us to think about specific, I would say, geriatric syndromes that we haven't had great familiarity with in the past. So let's talk about, I'm just going to go past the practical considerations in the annual wellness visit and go to the depression screening. Sorry. Oh, okay. Sorry, I think this is a little bit out of. Okay, so depression screening first came to many providers under the term meaningful use. And I think what meaningful use means to many people is this checklist that they had to get through to certify their electronic health record. And so what providers would find was that they were required to do a depression screen, and in order to eventually get reimbursed for the for the cost of implementing electronic healthcare system. But what meaningful use had a larger vision, and that was to make sure that the certified electronic health record improved quality, safety, efficiency, and many of the other sort of public health domains that we hadn't looked at before. And so meaningful use required that we had documentation of things that prior to the implementation of the Affordable Care Act. So these things almost collided in the sense that meaningful use was mandated so that we would get reimbursed for the use of the electronic health record and the cost of implementing it. At the same time, the Affordable Care Act came down with these provisions that included screening for depression. And that's why I wanted to use depression as a specific example. So what happened then is when you look at depression screening, you had this mandate for the electronic health record, Medicare rules under meaningful use that you have to have a screen. Then the annual wellness visit came down the pike under the Affordable Care Act and said, well, that is part of the screen that we would like you to use in order to fulfill the requirements of your annual wellness visit. And then you have expert groups like the United States Public Services Task Force that say, yes, you should screen for depression, but probably only if you have the staffing and the support system in order to treat depression if you should screen positive. So it became sort of this checklist of competing interests in terms of whether or not depression was something that, yes, it sounds like I should screen for it, but I have to be very careful if I don't have the resources to treat the depression if I find a patient who's severely depressed. And so it goes back to my previous message about chronology, not physiology, about physiology and not chronology, and trying to develop a personalized approach to each patient, because for any given patient who screens positive, you're going to have a workflow that allows you to do something about that positive screen. So once you find depression, the reason why the United States Public Services Task Force, which is a group of researchers that are mandated nationally to give us guidelines, said, whoa, wait a minute, you have meaningful use, you have the annual wellness visit under the Affordable Care Act. Let's think a little bit about what happens after a positive screen. And one of the provisions of the Affordable Care Act was, well, guess what? We're going to provide more in the way of mental health services for positive screens. That is to say that in the past, it'd been very hard to get counseling services covered, services that didn't just throw medications at you, but that actually reviewed potential behavioral modifications for depression. Those services were not often covered in the past. But with the Affordable Care Act, those services are covered just like they would be at treatment for hypertension or treatment for cardiac disease. So that was one of the really, I think, progress in the Affordable Care Act was this concept that mental health treatment, if you can find providers to help you provide those treatments, will be covered in a way that hadn't been the case previously. However, what's interesting, though, is that there was not as much uptake on the depression screening and utilization of subsequent services as people thought once the Affordable Care Act kept pushing the concept of annual wellness visits. And we think it's largely because meaningful use had already been around when the annual wellness visits really kicked in. And also society recommendations, including the United States Public Services Task Force, were a little bit conflicted on the idea of what do you do with positive screens if you don't have the resources to treat the depression. The other area that I just want to highlight before moving on to some of the other new provisions is what's happened with cognitive impairment screening under the Affordable Care Act. As you remember from the earlier slides that I showed you, it is part of the medical assistance checklist, or it can be part of an intake questionnaire if you provide the questionnaire to your patient before they even come to the clinic. And it basically asks you, is anybody, including yourself or any observer, I mean, using the word observer is a little bit concerning, but it was like, does anybody, including yourself or an observer, have a concern about your cognition? And if you screened positive, then, and again, just like with depression, a cascade of events should occur, and this should go into the provider template at the end, talking about, well, what are you going to do about that? And just like with depression, you can start to address the nitty-gritty of what you're going to do, either as a modifier during that visit or a separate visit. And what's really interesting about cognitive impairment screening, though, is that it led to a battery of sort of the geriatric cognition workup that many of you are familiar with, including history, MMSE or MOCA, depending on what you're more familiar with, laboratory testing. It didn't exactly prescribe what exactly to test, but there were many expert groups like American Geriatric Society and the Alzheimer's Society that were very willing to pitch in and give their opinion. One of the other provisions was that down the line, if you wanted to go to the next level of testing, neuropsych testing was now going to be reimbursed for someone who screens in positive. And interestingly, the neuropsych reimbursement was the same or very, very similar whether you had a technician administer the test or a full-on PhD. So there are a lot of nuances about this cascade of cognitive impairment workup that really was sort of, work in progress once you start doing the screening on any given patient. Next level then is, okay, so you've got a diagnosis, you're concerned, you don't have a definitive diagnosis, but you have clinical criteria for a dementing process. Well, one of the next provisions that kicked in is that imaging is covered. Under the provisions under Medicare, it's imaging NOS, but it does mean that either a CT or MRI is actually covered now. Interesting, some Medicare managed care agencies have said, go right to MRI because I know what you're going to do. You're going to do a CT and then you're going to come back and order an MRI, and it's probably more cost effective to go right to MRI at this point. Well, then of course you could just imagine that led to the next level of complexity. Well, what about all of these fancy new scans? And patients want those and families want those. Well, Medicare has made a decision back in 2013, and the decision still holds with a few subtle changes. One is that an FDG PET scan, and we'll talk about it, I'll describe what that is going to be covered, but only if it's a very atypical form of dementia that leads you to believe that it's a frontotemporal type of dementia. And without belaboring this issue, PET scans are considered true functional imaging in that metabolic activity goes to various parts of the brain, and you can get an idea of whether or not this is more likely to be Alzheimer's, or if there's a lot of changes in the frontal lobe, maybe this isn't Alzheimer's, maybe this is frontotemporal dementia. So it was kind of covered under that very small group of people where you thought it was something atypical. More recently, though, what Medicare has decided is that they will also cover these scans in the setting of research. That is what is called CEDs, which is coverage with evidence development, which means that if you're in the middle of a study, you can get this study. And more important, that allows patients to potentially go to a center where they can get an amyloid scan. And again, the purpose of this talk today is not to go into the nuances of amyloid scans and how they're different from PET scans, because really what it is, an amyloid scan is that you're just adding a specific tracer that binds amyloid, but just to show you how what started out to be annual wellness visit can potentially be a very interesting set into play, a sort of a domino effect of provisions and testing and evaluation that is now in play much more than it was before the Affordable Care Act came around. And with these amyloid scans, you have to, again, it's only covered under the setting of what they call coverage with evidence development. And these are very expensive because of the additional imaging compound, which is injected intravenously, that does bind to amyloid. And interesting enough, this whole concept of coverage under evidence development is growing and growing and growing, with more centers, including our own UW, that has this provision for patients who qualify under that cascade of events. So what led to just, is anyone worried about your cognition, to then the typical history and physical and clinical criteria can result in patients getting very complex workups, with the understanding that these latter pieces of the workup are really only available in a research setting. But you can get all the way to the point of an MRI now, and that was just not the case even 5-6 years ago. So with that, the patients are going to say, well, what am I paying for? And it's the same as any other provision of Medicare. Beyond that annual wellness visit, which is free with no copay and deductible, all these additional tests and services are going to fall under the usual Medicare requirement, which is often a 20% copay. You have to fulfill your deductible for the year. And then, of course, there's always that lurking issue of the facility fee, which many of you are familiar with, which is what is charged if you're in a hospital-based setting. And the facility fee is probably going to be one of the things that is many people are going to be interested in. There's many people already interested in phasing out under Medicare, and who knows what's going to happen to that facility fee, where you go for your MRI, you get charged for the test, you get charged for the radiology fee, and then another fee called the facility fee comes up because you happen to go to a hospital setting for your evaluation. So these are just all the complexities of what happens when what starts out to be preventative care brings in all of the comorbid problems that many of our patients carry with them. So this is just to highlight that Alzheimer's Association and the National Institute of Neurologic Disorders are absolutely thrilled with this progress in working up cognitive impairment. They want early detection. They want early detection in a setting such as the annual wellness visit. And just stay tuned, because things are going to get very interesting as we progress to getting higher and higher technology tools to make these evaluations. So I now want to move away from the annual wellness visit and talk a little bit more about some of the other provisions in the alphabet soup that has come to us with the Affordable Care Act. So this is case number 3. Case number 3 is Mr. AA, who's a marginally housed 75-year-old man. He has multiple medical problems, including heart failure, peripheral vascular disease. He has issues with polysubstance abuse. He's had a recent amputation of his foot for osteomyelitis and has been in a SNF, skilled nursing facility for 7 weeks. He's now supposed to be discharged to home with close follow-up. He lives in low-income housing. He has no phone. He has very little in the way of emergency contacts or legal next of kin, so he has to be contacted through the front desk. And he is very much at risk for landing right back in the hospital again, not necessarily because of his foot, but because of his heart failure and his issues with polysubstance abuse, which then often lead to noncompliance with his medications. So patients like that, especially in our, that are in very marginal social situations or don't have much in the way of supports, were part of the reason why they developed the TCM code under the Affordable Care Act, which, believe it or not, started in 2013. So now we're 4 years into the TCM code. TCM codes, people were very excited about that. It was basically a code that when a patient made a transition from a hospital skilled nursing facility or even inpatient observation stay. So it didn't even have to be inpatient status. It could be a hospital observation stay, their provider team could be reimbursed for the 30 days after they were discharged for all the complex issues they were going to bring to the fore. And this reimbursement, and I've updated all the reimbursement codes for you based on Medicare charges for last year, was about $170 to the provider team, and then $99 for the facility fee. And the two numbers there are the less complex on your left and then the more complex on your right. So $170 to the provider team, and then another $99 for the facility fee. Again, a fee that everyone's looking, not everyone that works in a hospital, but a lot of people in Medicare are looking to phase out. So what that entailed, though, was lots of fine print that has led to variable interest in using TCM. And what it was first of all, your service code has to begin on the day of the qualified discharge. So that's day one. And then you had to basically have a 30-day plan for that patient that included everything from documentation starting on day one to at least one visit within the next 30 days. And so the fine print became one that was quite tedious for many provider groups, although I must say some provider groups have successfully done TCM and made it a part of their workflow with minimal difficulty. So one of the things you had to do was you had to contact the patient within 2 business days of discharge from either the skilled nursing facility or a hospital stay. And an ED visit didn't count, so it had to be one of those inpatient type settings. You had to document that you tried to contact them. Ironically, you didn't have to be successful, but you had to at least note that that was attempted. The note had to come from the clinic. It can't come from a lot of hospitals have a phone call that they provide to the patient within 2 days of discharge. That did not count. This had to be driven by the provider team that is in the outpatient setting. And then you had to document along the way what you told the patient, interaction with other providers, interaction with other caregivers, education, and then a referral plan. And then you had to actually see the patient within 14 calendar days if it was the less complex TCM code, or 7 calendar days if it was the more complex TCM code. Fortunately, the face-to-face could be could be telehealth, which I think was a new, fairly recent provision, which has greatly helped those of us who aren't able to meet with patients face-to-face. So a qualified telecommunication system worked for that requirement. And this code could be used even if the patient was readmitted. In other words, if despite your best efforts, the patient was readmitted during those 30 days, you still got reimbursed for your time and efforts in transitional care management. But only one provider, so if another provider wanted to pick up that patient for their discharge during the second hospital stay within the 30 days, that wasn't going to work. Only one provider can use this at a time. So this has been a very interesting code. It's been one that I think has a lot of promise for very busy practices that have care managers that can reach out to patients who are in and out of the hospital frequent times, but has not gotten, certainly at our hospital, we have not been able to institute TCM. And interestingly, the most difficult part has been getting a hold of the patient. And although you don't have to be successful in reaching them those first 2 days, you do have to be successful in getting them an appointment within either 7 or 14 days. And for a lot of patients, that can be difficult to do. You can go to their home to qualify for that 7 or 14-day visit. So that is, as well as you can use telehealth. But again, you have to have a system in place that has a lot of care coordinators to use this provision. The next provision is called TCM and is highlighted by this case number 4. Mrs. AL is a moderately demented female with hypertension, severe glaucoma with only large print vision, osteoporosis, and falls. She comes in every 3 months to senior care clinic for IV bisphosphonate. She calls about once a week asking for a med refill, and ironically, she only asks for her vitamin D.
think your microphone might have fallen down.
Okay, sorry. She calls the medical staff about, as I said, once a week because of her vitamin D concerns, and ironically does not get some other meds because she has some mild cognitive impairment, and her focus, for reasons that are unclear to all of us in clinic, is her vitamins. So she lives with her nephew, who really can't help her very much, and she has moderate cognitive impairment, and only gets to the clinic visits because of HopeLink, which is a ride service for our low-income patients. So she illustrates the importance of CCM, which is chronic care management services. This began 2 years ago, and basically is a provision under the Affordable Care Act that Medicare pays for care coordination to Medicare beneficiaries with 2 or more conditions, which of course constitutes over 2/3 of Medicare beneficiaries qualify for that under that definition. So that is to say, if you only had that criteria, which is 2 or more chronic conditions, 2/3 of Medicare beneficiaries would qualify. The reimbursement for basic CCM is about $40 a month, which is the fee to the care team, i.e. the providers. And then again, you see that F keeps coming up, $32 to the facility if it's in a setting like a hospital where a facility fee is always generated. So there would be no facility fee if you were not in a hospital type setting. So CCM requires actually only 20 minutes of staff time per month for a patient with 2 or more chronic care conditions to qualify to enroll that patient. This 20 minutes assumes that about 15 minutes is going to be provided by a qualified healthcare provider, a nurse practitioner, PA, physician, but that in aggregate you just have to meet this 20-minute rule. And that seems pretty attainable for the majority of the patients who fit this criteria. Other fine print is that these chronic conditions have to be what you would imagine: diabetes, heart failure, things that really could impact upon that patient's risk of death, hospitalization, or losing their independence. The problem with CCM, and for many people who've tried to use this code, is that you have to establish a comprehensive care plan. And this care plan has a checklist. As you could imagine, like everything else under Medicare provisions, there's a checklist. And that checklist has to be in play for at least 12 months or until the death of the patient. And so what happened was that most people thought, wow, a checklist, a care plan, 20 minutes, sounds good, but it really does not meet my needs in terms of workflow for the complexity, for the patients who I think would benefit most. So recently now there's become a new code called Complex CCM. And it has upped the bar significantly in terms of what it now provides. It's complex care requirement. The reimbursement level on average across the United States is $93 to the provider team. The expectation is 60 minutes of clinical staff time directed by a physician, nurse practitioner, or PA, with the expectation that the provider's input during those 60 minutes will be about half. And that 60 minutes is based on calendar month. And now there's going to be additional CPT codes for additional 30 minutes. So the whole idea here was that they were recognizing that by the time you created a care plan and a checklist and a to-do list for these patients, you really were well beyond the 20 minutes, and that really creating a 60 minutes with the provision for additional minutes was going to be what really made CCM doable for many practices. So what is the fine print of CCM? Well, the patient, and in addition to what I've already told you, the patient has to be actively engaged in the process. And initially, they had to have a face-to-face consent. And the consent form was daunting. It was like, I know that these provisions are as follows. They can be canceled at any time if I don't participate. And it was really quite daunting. So in addition to creating complex CCM, Medicare has recently decided that the consent process was too much of a barrier for implementation. So now you only have to have a face-to-face consent if the patient has not been seen in 12 months. And I would argue if the patient's not been seen in 12 months, they probably aren't as complicated as originally thought. So the consent process has been markedly loosened. It can be telephone consent if the patient's been seen within the last 12 months. So that's really nice. And with that consent process, the patient has to be informed that there might be some cost sharing. It's the same 20% rule if they don't also have Medicaid or some other way to pay for their copay and deductible. They need to understand that for any given month, only one practitioner can bill for CCM. So you can't go to a primary care doc near your home and then to another primary care doc in the city and expect both of them to have you under their CCM network. And that you have the right to stop CCM at any time. The patient has the right to withdraw from this at any time because the whole idea is informed consent for them to engage in this. So this all comes out to be quite an amazing amount of provisions and policies, but it isn't even the newest provision that's come to play. Many of you probably know that the newest provision that has come under the Affordable Care Act is the whole concept of advanced care planning. So as you might remember from my initial slides on the annual wellness visit and the idea of what you cover in the annual visit, for those of you, I raced through some of those old slides just because although I wanted you to have them in your packet, the annual wellness visit has been around for a long time. I really wanted to, and I wanted to get to these more recent codes. There was a point where you noticed that as part of the annual wellness visit, if the patient wishes, you could do advanced care planning. Well, many providers pointed out that advanced care planning takes a long time and should probably be something that's recognized as a separate entity under Medicare that really shouldn't be part of the, do you wear your seatbelt? Do you have a up-to-date fire alarm system type of checklist approach? So effective a year ago, Medicare started to pay for voluntary advanced care planning. And you'll see the word voluntary a lot when you look at advanced care planning. And that word voluntary came from the concern about death panels and all that unfounded fear that if we pushed advanced care planning onto our patients, we were somehow making them select a topic that they just really did not want to approach. So it's voluntary. So with that, Medicare started this a year ago, and it is now something you can do separate and that you get reimbursed from based on 30-minute increments. So the concept here is that separate from anything else you might want to do, you can discuss the patient's wishes, intentions. You can fill out forms if you wish, but you don't necessarily have to. And that if it takes 60 minutes, you can have an additional 30 minutes that you bill for. And if it takes multiple times in a year, you can be billed over and you can bill for this throughout the year. If a patient has a devastating cancer diagnosis and things seem to be going very badly for them, but then suddenly something happens and they respond to some new monoclonal or whatever, you need to reestablish their advanced care directive. The whole concept of this is that this is fluid and it's reimbursable for actual time spent. The trick with this, not trick, I don't want to call it that, is that you do need to spend a minimum of 30 minutes. And as an experienced geriatrician, I find that a lot of my patients, especially those in their 90s, are like, no, forget that. No, 5 minutes and I'm done. They have their pulse. They're like, no, just keep me comfortable, doc. I'm good. And so what you do there then is you wouldn't be able to use the CPT code. You would just put it under evaluation and management and either do time-based billing as part of, you know, the hypertension check or the heart failure check, and not use this. This is really for, you know, the family meeting type environments where it is going to take at least 30 minutes and possibly much more. So I think I've covered, I hope I didn't race too quickly through the annual wellness visit. I hope I've covered many of the provisions from Medicare that have come to play under the Affordable Care Act. I want to say that the uptake on these is what you would expect. Going back to the annual wellness visit, I found a recent report, and this will be in your slide deck, that in Detroit, they looked to see what is the uptake on the annual wellness visit in beneficiaries in the Detroit area and the Detroit suburbs. And they're projecting that by this year, or by the end of last year, beginning of 2017, about 20% of affluent white Medicare beneficiaries had an annual wellness visit or were planning to have an annual wellness visit. So the uptake's only at 20%. When they looked at the African American population, the uptake was less than 10%, but it was because most of the responders said that they wanted to spend their clinic visits talking about their health issues. And in fact, when they looked at the number of health issues that the two different groups had, that did explain much of the difference between a 20% uptake in doing the annual wellness visit and the 10% uptake among patients who have a lot of comorbidities, whether they also had additional socioeconomic stressors. So it's not going gangbusters. So I think the value of the annual wellness visit remains to be seen, but it certainly has highlighted, at least for me, the complexities of depression screening, because I was already doing like this meaningful use checklist, and then the annual wellness visit came around. And I think it's made the whole idea of cognitive impairment screening even more complicated, because the dementia specialists are telling those of us who see a lot of older patients, hey, we want early detection, we want early evaluation, because we think that not too long from now we're going to have early interventions. So it's really making those two entities, at least for me, very interesting, and I think it's going to be a very dynamic process moving forward. The TCM code is helpful, but it's been burdensome, and I think the uptake on that has not been as good as expected. Fortunately, they have said that the face-to-face component can be done via home visit or telehealth, which is great. And as many of you know, a lot of the reimbursement rate for home visits, although not stipulated as part of the Affordable Care Act per se, but has, at least in the Seattle area, gone up to a point where I am more than happy, especially if I don't have to drive all around the place and can do it on a weekend, to substitute a lot of my clinic visits for home visits. So in addressing your question, the concept of adequate reimbursement for home visits was not actually a stipulation of any of these codes. It just came to play because people demanded it, and it just became the right thing to do. The CCM code is burdensome in terms of rollout because it has a long checklist, including the patient's consent. But now that the patient's consent can be over the phone as long as they've been seen within 12 months, and they have these new chronic complex CCM additional codes that allow for roughly, I believe it looked like it was definitely double and almost triple the monthly reimbursement to the clinic. I think this complex CCM code is going to be the most exciting aspect of a lot of these provisions. And then last but not least, reimbursement for advanced care planning is a welcome provision. I think it's especially helpful for our palliative medicine colleagues who potentially have much more complicated scenarios. For someone like me who takes care of people in their 80s and 90s, I very rarely find that it takes a full half hour to discuss advanced care planning, but certainly it's a welcome provision for many other providers. And I believe that that's it for now. And I guess I take questions or no?
So I've got some questions that I'm going backwards on May, and if you wouldn't mind repeating them into the microphone. The first one is this EMR have had the most success with the wellness, welcome to Medicare or annual wellness visit?
Oh, yeah. So can I go, is there any way I could do slide sorter?
I don't know.
Slide sorter, so that I could see all my slides? Or do I have to scroll back?
You do have to go back, I'm sorry.
Oh, okay. So I guess I am, University of Washington has 3 medical records, 3 EMRs right now. My understanding, and this is truly an objective point of view, is that because Epic gathers so much population data as well as individual data and can create so many different types of templates, which you design yourself very easily with their smart phrases and their smart sets and their smart links, is probably the one that I've heard people have been successful at doing the annual wellness visit. And certainly that's the one that some of the hospitals in the university system here have used, is Epic. But that doesn't mean others haven't been successful.
And then Fairbanks, and again, I'll need you to repeat the question. How often?
Do you mind if I switch around slides if I want to highlight something?
Yeah, you're welcome to.
Okay.
How often are you doing CSF analysis and dementia workup? Which specific studies are you ordering?
Right. So interesting that you should say that. That's a very good question. So the I just looked that up, and the NINDS, which is the National Institute of Neurologic Disorders at NIH, and has just decided that they have no consensus on CSF. And in fact, the only consensus that has been agreed upon by all of the players in cognitive assessment has been the clinical criteria for probable Alzheimer's disease, and the clinical, and then the pathologic criteria for probable Alzheimer's disease. There is also criteria for frontal temporal dementia based on imaging, because the changes in the frontal lobes are so striking, but there is no consensus on use of biomarkers or imaging for Alzheimer's disease. So I hope that answers your question. So the point is that clinical criteria and then neuropathologic criteria based on autopsy tissue are the major consensus statements right now, with no consensus on CSF or neuroimaging for Alzheimer's per se.
And maybe, I think you saw this question, so maybe you did address it fully. Where does home health fit into this?
Yeah. So home health is still reimbursed, as many of you know, based on the need for skilled nursing or physical therapy evaluation in a homebound patient. So again, you have to meet the criteria for home care, which is homebound, which means you can't get out the door by yourself. So even if you're in a wheelchair, you can get out by yourself. You're not considered homebound under Medicare. And then a skilled need, either nursing, physical therapy are the key points, and then they can get social work or occupational therapy. And then the actual issue of the provider visits are like any other clinic visit, except there's no facility fee. So basically, when we talk about home care in our practice, we just do it. And then we create an outside care encounter and bill in our billing system with no difficulty. It's just that the hospital system has to come to terms with the fact that you did not generate a facility fee. But the reimbursement, as many of you know, for a home visit now makes them feasible financially. But the whole issue of home health with the RN and the PT plus or minus OT and social work is a separate domain which requires a skilled need and homebound status. So they're kind of different, if that makes sense. I don't know if anybody has questions on that.
So everyone, I've just moved up to the table. I've been sort of staffing the door so the door opening and shutting doesn't bug you. But that should resolve your concerns about the questions being repeated, because I've just been reading the questions off of the chat box. They're not questions that have come from the room. So here's the next one, which is please, never mind. That was the same thing about home health and doctor's visits. And I think that's all I have from the chat box. So let's see if we have questions from the room.
Let me just answer just to go back again, the question was about home visits. And what I wanted to highlight was home visits by a licensed provider, nurse practitioner, PA, physician, can be done as long as the patient is homebound and they let you in the door. You just bill. That's fine. You have to certify that they're homebound. Home health, i.e. via an RN, PT, and then OT and social work if needed, are event-based provisions, i.e. you have to have a skilled need. There has to have been an event or a reason why that's brought forward. So there are different things that can be done in parallel, but are different parts of the patient's care plan, if that makes sense. The slide can people see the slide I'm showing now?
Yes.
Yeah. I wanted to go back to this slide just because I wanted those of you who like looking at calculators to know about this calculator. One of the things that I said twice, but I wanted to reinforce, was the concept that preventative care has to be in the context of that patient's own comorbidities, their life expectancy, their goals for the rest of their life. And one of the things that my colleagues at UCSF have created is an eprognosis.org. And I just wanted you to take a look at this because eprognosis.org just gives you an idea of, for any given patient, what are the drivers that are going to change their life expectancy or change what you expect in terms of their future quality of life? Because especially with things like the annual wellness visit, you really have to decide, well, if the patient's really not very well, should I even be doing this type of visit? And is this a good use of their time, or should we be just focusing on their medical comorbidities? So just wanted to show that slide again.
Then there's a question from Montana State. Which portions of the TCM and CCM are done by registered nurses?
Oh, right. So unlike the annual wellness visit, which I think I alluded to, I showed you the majority of we estimate that the MA spends 30 to 45 minutes, and then the provider spends 15 to 30, depending on how many parts of the checklist came up positive. The idea of TCM and CCM are very much nurse-driven. If you look at the way that it's written and the level of interaction with the patient that's required, we decided in our practice that the TCM and the CCM would, when they talk about 20 minutes and then now they have the provision for 60 minutes, it would almost all be an RN. And then there's that provision that the sign-off by a licensed either PA, nurse practitioner, or physician be roughly, if it's 20 minutes of CCM time from the nurse, that the provider probably had to put in another 15 minutes per month to review the plan, make additional recommendations, and discuss it with the care team. But yes, both of those codes are 2/3 nursing, 1/3 licensed provider. So that was another holdup. The nurses did not want to be on the phone even more than they already are, because a lot of it is done by the phone, on the phone.
Okay,
Yeah.
questions in the room?
I have a question. You opened the presentation with two case studies, one of Mrs. GE and Mrs. EG. And you said it's really hard to decide and make a plan for preventive care, and I just wondered what would you do in both of these cases? What do you say about preventive care?
Yeah, so the question was about preventative care and how would you design unique sort of, I guess, plan for very different patients. And that's why I did want to come back to this slide that I imagine, is everyone seeing this slide now? Yeah, on this whole concept of quality of life as well as life expectancy. calculators. Again, it's eprognosis.org. But going back to those two specific cases, and I will bring, I should just highlight them. So what we would recommend, or I would recommend, is that for the patient who has multiple comorbidities, I don't find that I even get to this checklist in their visit. I mean, you try. First of all, would you even try? And what I do for the patients who have a lot of comorbidities is I have the staff call them ahead of time, and that's where these dear patient, either letter or usually for our patients it's a phone call, explaining to them what a wellness visit is, and a lot of them will say, no, I really don't have the kind of focus on preventive care that sounds like. I would really like to discuss why I'm short of breath whenever I walk whenever I walk across my kitchen. So the patient themselves will dictate much of the preventative care. And so I find that the patients will tell me that, there they are. The patients will tell me that what their goals are for that visit. And so it hasn't really come up that much. The patients who want to do the annual wellness visit, I think are some of the most difficult visits, because they can end up wanting an hour or 2 hours. They want to discuss what they've seen on the internet. This is the healthy aging population, which we love taking care of, but who really know a lot. And they read a lot, and they want to discuss a lot. And that's the challenge at the other extreme, are the people who are in their 70s and 80s and skiing and playing tennis. So it's you probably, as their provider, are going to know for each patient which group, what that patient's goals are going to be for that visit. So I don't find that I find it's pretty easy to tell.
Other questions here? Do we have additional questions out of the sites?
And I put the references at the bottom.
Pardon?
I said there's reference, the link to a lot of these provisions is at the bottom of the slides. So you'll see that. I don't know if they get the slide. They get a slide with the PDF.
They get the handout, which has all of your slides in it.
Okay.
Yeah.
I'm curious, May. I mean, you just touched on your opinion that these things wouldn't change in the next few weeks, months. Why did you say that?
The question was, why do I think that the provisions under the Affordable Care Act for Medicare are not going to change? The main reason is going to be that, if anything, very powerful lobbies, including the AARP, want more of this, not less. They want more early detection of depression and cognitive impairment. They want more options for healthy wellness. They want more options for care management and complex care management. And I just think that their power to get their desires across is going to make it very difficult to take anything away from these type of provisions. And I think that's what most geriatricians believe. The concern is going to be, obviously, if you have the payment form, right. So obviously if it goes to privatization or block grants, then it's going to be much more difficult to provide all of this without the obvious savings already in hand. But regardless, I don't think the actual provisions can, most of them, I don't think they can go away now that people have gotten a sense for how much they provide in terms of potential quality of life for older people.
Okay. I think we're done. Thank you so much, Mary.
Yeah, sorry, I feel like I raced through I was like, I wasn't sure how much I should do about annual wellness, because it's so, when I realized, it's been 7 years, 6 years. Do you do it here? Do you guys know what